Hello and welcome. I'm Hanya Salah, the Director of Columbia University's Global Center in Amman. We are delighted to have you join us today for a critical conversation about the humanitarian and medical challenges faced in the aftermath of war. This webinar is co-sponsored by Columbia University's Program on Forced Migration and Health and the Columbia Global Center Amman, in partnership with the American University of Beirut's Global Engagement Initiatives. It is the second session of a four-part series entitled After War, Learning from Past Conflicts, from the ethical dilemmas faced by journalists to the mental health impacts of war and the economic and urban obstacles of post-conflict recovery and reconstruction. Each discussion aims to offer insights on rebuilding societies torn apart by violence. Today, we will focus on the strategies and challenges of providing effective healthcare and humanitarian assistance to war-torn communities. With the ongoing wars and current conflicts in our region and beyond, the urgency of addressing the humanitarian and medical aftermath cannot be overstated. Now, I would like to extend a warm welcome to our esteemed panel of experts. James Orbinski, a renowned figure in the health humanitarian field, served as the international president of Médecins Sans Frontières and accepted the Nobel Peace Prize on their behalf in 1999. James is currently a professor and the inaugural director of York University's Dahdaleh Institute for Global Health Research. He has been a member of several bodies committed to improving health equity around the world and was a co-founder of Dignitas International, an organization dedicated to innovative, sustainable solutions to global health challenges. James is an officer of the Order of Canada and received the Meritorious Service Cross for his leadership in providing direct medical relief during the genocide in Rwanda. Zahi Abdul Sater is a senior advisor for partnerships and innovation at the Global Health Institute at the American University of Beirut. He brings invaluable expertise in addressing medical challenges in post-conflict settings, particularly in the Middle East. His role in launching the Eye Protect project at AUB contributed to developing medical responses to war injuries. Additionally, Zahi's pioneering work in biochemistry and cancer research has paved the way for innovative approaches to medical care. Eveline Hitti is Chairperson and Professor of Clinical Emergency Medicine at the Department of Emergency Medicine at the American University of Beirut. She also oversaw the establishment of the first emergency medicine training programs in Lebanon and leads multiple capacity building and workforce retention initiatives. Her research has focused on applying and developing evidence-based health management practices and on the indirect impact of violent events on emergency department usage, disease patterns, and patient conditions. Saman Zia-Zarifi is the Executive Director of Physicians for Human Rights. Sam is a leading voice in global human rights advocacy with over 3 decades of experience as an international human rights lawyer. Previously, he served as the Secretary General of the International Commission of Jurists, where he helped launch and lead initiatives on strengthening global accountability mechanisms, as well as response to public health emergencies. He has also led Amnesty International's Asia and Pacific program, as well as several teams at Human Rights Watch across the world in settings like Iraq, Pakistan, and Thailand. Moderating today's discussion is Monette Zard, the Alan Rosenfeld Associate Professor of Forced Migration and Health and the Director of the Forced Migration and Health Program at Columbia University. Monette's expertise has contributed significantly to advancing research and advocacy efforts in addressing the challenges of post-war recovery. She has consulted on international human rights and forced migration issues for several organizations, including Amnesty International, the Brookings Institute, Human Rights Watch, and the United Nations High Commissioner for Refugees. Now I will hand it over to Monette. Thank you.
Great. Thank you so much, Hanya, and welcome to our distinguished panelists and also to you, our wonderful audience. So today's panel is tasked with exploring some of the humanitarian and health challenges that we can anticipate in the aftermath of war as societies move towards addressing the pressing needs of populations that have been impacted by conflict and begin to rebuild health systems that have been impacted or even decimated by violence. This includes building health infrastructure and, of course, the health workforce that are the lifeblood of any health system. Now, as conflicts rage around us, it is hard, of course, to sort of lift our heads up and imagine the period when the violence stops. This week marks the one-year anniversary of the conflict in Sudan, a conflict that has killed tens of thousands of people and forced more than 8 million to flee their homes. In Gaza, more than 34,000 people have been killed in just over 6 months, with over 1 million displaced, while the fate of 100+ hostages in Gaza from Israel remains unknown. Long-running conflicts continue to simmer in Syria, Yemen, and of course, beyond the MENA region as well. Now, while every conflict has its own particularities, we see similar trends across many of them. Constraints on humanitarian access, attacks on humanitarian workers, attacks on health infrastructure are all, unfortunately, an increasing feature of many of these conflicts. And beyond the direct injuries suffered, there are indirect impacts as well. The threat of famine has explicitly been flagged by the UN in Gaza, Sudan, and Yemen. The mass displacement of populations and the flagrant disregard of humanitarian law by both state and non-state actors is an all too common feature of contemporary warfare. And these are the rules that are put in place to ensure and mitigate the worst impacts of conflict when it comes to the civilian population. But the post-conflict period will eventually come, either because a clear victor emerges, conflicts fizzle, or a political settlement is reached. And it is critical to think about and plan for it, both as policymakers, as humanitarian practitioners, and as medical workers. What needs can we anticipate on the part of the populations we serve? And in a context of massive need, how do we prioritize or sequence our response? What capacities, human and otherwise, do we need to build and restore? And beyond capacity, what values do we want our health systems to embody? Now, some of the answers to these questions are shaped by the nature of the conflict themselves and the types of violence experienced by the civilian population. For example, where a conflict has been characterized by widespread direct attacks on healthcare, as we've seen in Syria and currently in Gaza, how does that shape what the post-conflict reconstruction process looks like? And in conflicts marked by widespread food insecurity and famine, what kinds of long-term, even intergenerational needs can we anticipate on the part of the population? The nature of the conflict and the peace also influences who will be the main actors in any rebuilding process and what legitimacy they carry with them into that process. And finally, I think it is important to note that the term post-conflict itself is rather opaque and amorphous and very much in need of critical reflection. And I think it's important to unpack it because it shapes and defines the terrain of what is possible in terms of reconstruction and rebuilding. Is it purely the cessation of hostilities, which could come about in part because warring parties have run out of resources or their political and financial backing has shifted? Or is it something more sustainable and durable, a negotiated peace in which transitional justice and accountability processes are built in so that victims on all sides are able to access redress and remedy? Thankfully, our expert panel will help us to unpack and begin to probe some of these questions. This session will run until 1:15, so we will have time for your own questions as well. So please do put them in the Q&A box over the course of this discussion. But first, let me turn to our first speaker, Dr. Orbinski. James, can I ask you to share with us first some key lessons that you have learned from your own extensive international work in Rwanda and elsewhere on what some of the central challenges are that we can anticipate in terms of post-conflict reconstruction of the health sector in places like Gaza and Sudan?
Sure. Thank you, Monette. So let me just make a couple of quick comments, but first let me thank the organizers for bringing everyone together. Tanya, Zahi, Eveline, Sam, you are really some wonderfully distinguished co-panelists in terms of your own thinking, your own engagement with issues. And it truly is an honor to be here and to participate in this discussion with you. And I would say, just let me begin by saying that this is a discussion, just as in the reality of conflict, one engages in a dialogic process with actors in that particular context in pursuit of an ideal. And in pursuit of a form of practice. And we're talking here, obviously, about humanitarianism and war. And what I would say, is that just to kind of frame in the broadest possible terms, what happens in war affects what happens post-war. And so the conduct of warfare and the manner in which humanitarianism is seen and practiced is absolutely central to what emerges as possible or to the range of possibilities in a post-war context. And let me just say that following 6 months of ongoing warfare in the Gaza region, following the October 7 Hamas attacks on Israel, and now today, Iran's retaliatory drone strike on Israel, the Middle East is very clearly in crisis, and the world is seized literally by the minute of developments in that particular context. And the EU foreign minister said this morning that we are on the edge of regional war in the Middle East, and we are I think members of this panel are deeply aware that extends to global implications, not simply in terms of warfare and the codification and engagement of various alliances and other political actors. But in terms, most importantly, in terms of what we're talking about today, in terms of how humanitarianism is seen and actually how it is pursued. And I would argue that we really are literally in the midst of a hinge moment globally and historically in terms of how humanitarianism is seen and practiced. And let me just focus on what is happening now in Gaza and use that as an opportunity to talk about some very basic humanitarian principles. So we're seeing both Hamas and Israel engaged in conflict. And Hamas has attacked Israel as of October 7, continues with missile launches into Israel, is holding hostages, and Israel's response has been massive, overwhelming, and ongoing, with profound implication, not just implications, but practical outcomes for literally millions of people. Israel is conducting siege warfare. Now, siege warfare is outlawed by the laws of war and has long been outlawed by the laws of war. Israel, in its response, is using massive, and in my view, and I think fairly obviously, a massive and disproportionate response to the threat that Hamas has posed to the state of Israel. It is failing to discriminate between civilians and Hamas combatants. There is a conflation of the Palestinian people as a civilian population with political rights. There's a conflation of the people of Palestine with Hamas. They are seen by the state of Israel as one and the same. And there are repeated and massive violations of very basic parameters of humanitarian law. So we see ongoing systematic bombing of hospitals, targeting of cultural sites, and so on and so on. And so if I were to just say that, let me just finish this opening set of comments by saying that there are principles for humanitarian actors, and there are principles for belligerents. And the principles for belligerents are proportionality, discrimination, and the responsibility to ensure humanitarian assistance and protection. And the principles for humanitarian actors are to maintain neutrality around the causes of war, not the conditions of war, but the causes of war. And they are also to act impartially, which means essentially responding only on the basis of need and need alone. And then thirdly and finally, they are to remain independent of the political actors and the political issues at play in the particular context, so that they are able to exercise their humanitarian action. Now, whether the principles are for belligerents or for humanitarian actors, in all cases, they are underlaid by the most simple, but at the same time, complex principle of humanity. And humanity, I can just, if I could wax poetic on this for hours, but I simply operationalize the term humanity with another ambiguous term, which is dignity, which is to see the dignity of each and every human being, the sameness of self in the other, for example, in all human beings, whether they're belligerents, whether they are enemy civilians, or regardless of their political status, to see that sameness of self, to see that dignity. And that is the basis for which any possibility of a peace is rooted in. And that means then that the principles of neutrality, impartiality, and independence for humanitarian actors, and the principles of proportionality, discrimination, and respect and responsibility to ensure humanitarian assistance, that these are operationalized from that basic starting point. And I think from there, I'll just stop and allow other panelists to offer some initial comments. Thank you.
James, maybe just in just 2 minutes, if you could just extrapolate from what you've laid out in terms of what you've described as a hinge moment where some of these basic principles around humanitarian action are being challenged. Can you help us think about, as we move into any conversation around reconstruction, post-conflict, what some of the implications of these practices might be for how we approach that?
Well, I'll give you a very simple and concrete example. Post-genocide in Rwanda, I was asked by the Canadian government and by other governments, what should be their post-war or post-genocide priorities? And many were very much interested in building hospitals, providing food, medical, and other forms of immediate relief. And what I said to the Canadian government especially, and also to other governments, was that, yes, I understand the need for immediate medical care and supporting that. But my advice was that if you were to partial out on a percentage basis what you're doing, I would say that the most important approach in a post-war setting is to focus 5% of your money on direct humanitarian assistance, on medical relief, on food relief, and so on, and focus 95% of your money and of your political capital on creating and supporting the reemergence of institutions that can enable a non-violent pursuit of justice. right? So that was a major issue in the post-genocide setting in Rwanda. Now, unfortunately, that advice was ignored. But I would say that says a lot, I think, about what are the fundamental priorities in a post-conflict environment. And remember, we know that in war and pre-war and war, there are massive movements and displacements of people. We're very aware of that, and the creation, there are refugees and so on and so on. But the fact is that there is a larger movement of internally displaced people post-war and a larger movement of refugees post-war than what one sees in war. And what that tells you is that post-war, the society, whatever society we're talking about, is under reconstruction. There is a reconfiguration according to whatever the dominant power that has emerged post-war conceives of as justice. So justice and the pursuit of justice around with strong input from the global community is absolutely central. And obviously, and final point, obviously, the pursuit of justice by definition is fraught with ambiguity, with dilemma, with uncertainty. But it is the dialogic process within which justice is pursued in a institutional framework that is central to maintaining and creating at least the possibility of a just future.
Excellent. Thank you so much, James. We will come back to you, and we'll come back to those critical ideas as well. But let me move to Zahi now. Zahi, thank you so much for being with us. And I would like to sort of drill down a little bit more into some of these issues, and drawing on your own experience and scholarship based around the long-term health impacts of the 2006 Israel-Lebanon war and the 2008 Marches of Return in Gaza. Can you reflect with us on what some of the key health issues and challenges might be when it comes to rebuilding health systems in places like Gaza, like Sudan? Both what are the health needs likely to be, but also what are the health capacities that the system should have that we should be paying attention to?
Thank you, Monette, and I'd also like to thank the organizers for inviting me to be part of the panel. So, Monette, you alluded to this maybe in the introduction that you gave, but especially when we're thinking about conflicts in the MENA region, in the Middle East, North Africa region, I think the first thing that we need to think about is the nature of war itself, right? So typically in wars, there's a definite start and then there's a definite end of fighting, which rebuilding happens afterwards, right? But if we look historically at our region, be it in Gaza, be it in Iraq and Lebanon, we see that we are in this sort of a continuous state of fragility, right? And then there's these spikes of wars and conflicts that happen. And each one is sort of a different intensity, let's say. So this is why in our research that we've done, we look at wars as endemic to our region, as in they are always happening in some form of way. So in Gaza, in Lebanon, in Sudan, these conflicts have been ongoing for a very long time. And it's quite hard to approach rebuilding health system at a specific point of time or in a specific intensity. I think rather we should approach it as this sort of a continuous and shifting process that really depends on the intensity of the ongoing conflict. So to give you a concrete example, the current war in Gaza will require a complete rebuilding of the system, right? Because from scratch, because the health system has been entirely decimated, right? At the same time, in Gaza, previous wars in 2008, 2012, 2014, the nature of the rebuilding process itself was on top of an existing healthcare system, and this is quite different in terms of how we approach it. The second point that I'd like to make is that, especially in endemic conflicts that we see in our region, we tend to always see this form of humanitarian and foreign aid addiction. And to illustrate this point, so in Gaza, due to the embargo that has been, enforced for quite a lot of time, a very basic material that is required to manufacture medical devices say, external fixators, right? These very basic materials are not allowed into Gaza. Instead, the only sort of entity that brings those external fixators are humanitarian organizations. So we end up in a setting of conflict whereby such medical devices are sorely needed, but there is no local capacity to manufacture them because of political issues, right? And what we've done, because I'd like to also offer solutions, is that what we've done in this case at the Global Health Institute is that we took biomedical engineers from Gaza to the UK. They sort of shadowed the manufacturing process of external fixators, but those external fixators were low cost and required very, very basic material that are actually available in Gaza. And to go back to the rebuilding health systems point is that when we're thinking about that, we need to make sure that when the health systems are rebuilt, there is unfettered access to material, unfettered access to equipment, right? And this is not limited by any sort of political or economic barrier. Also, we need to make sure that there is the local capacity to meet the needs of the injuries that happen. And we also should make sure that the funding that exists for the rebuilding of the health system, there is this balance between the immediate humanitarian need, but also rebuilding the intrinsic capacities of the healthcare system. And importantly, when we do that, we do not create the humanitarian assistance and foreign sort of aid addiction. The third point, when these sort of conflicts happen, we need to think also about the nature of the injuries themselves. There's a lot of long-term injuries, including amputations, and these injuries, they need a very long-term rehabilitation, treatment, and hospital readmission for a very long time. So to give you an example, in Gaza in 2008, during the marches of return, and we've done some research on that, there was more than 8,000 injuries. And when we looked at the nature of those injuries, most of them were disabling gunshot wounds in the lower limbs, right? And if we look at the demographics, it was mostly in young men, which are sort of which reduce the productivity that happened in Gaza. And then coupled to that, in health and in war settings, there is, in addition to we typically hear about someone being injured in one war and then them being re-injured in another war, and this is what we call physical re-injury. In our settings, there is also the traumatization and the re-traumatization, because these sort of population live trauma again and again and again. So when we are rebuilding healthcare systems, we should account for capacities that allow for the long-term treatment of clinical and mental health burden, but also consider sort of the context and nature of these injuries. And the final point that I'd like to make for this question is that we need to make sure that the training of healthcare professionals, which are sort of the core of the healthcare system, it matches the context. And what I mean by that is that if we look at our region in the Middle East, North Africa, most of the medical curricula are imported from the US or from Europe, right? Where conflict is virtually non-existent. They are made for medical care in peace settings, right? So what does that mean? This means that the health professionals in our region, where there's a lot of conflict, are not being trained to tackle injuries and public health issues that are specific to conflict, right? So this means that we need to work on the medical curricula that exists in our region to include the domain of conflict medicine. And what I mean by that is how medical care is shaped and undertaken in settings of conflict. And we took sort of the first step at the Global Health Institute. We were able to develop a 4-course certificate in conflict medicine for this very same purpose. So Monette, in a nutshell, when we're thinking about healthcare systems, rebuilding them in settings of conflict, we need to account for the endemic nature of war. We need to account for the long-term types of injuries, the addiction to humanitarian and foreign aid, and integrating sort of conflict medicine into the medical training and knowledge.
Very clear, and just very, very helpful for you to lay that out for us, Zahi. I have one quick follow-up question, maybe just in 2 minutes. I know in your own work, I mean, you've just outlined the long-term needs we're likely to see coming out of the kinds of injuries that have been sustained, some of the mental health sort of needs that we're likely to see. But I know you've also in your own scholarship looked at the burden of chronic diseases in the MENA region, and how caring for those with chronic diseases can be impacted by conflict. And I believe you looked at this specifically in the context of Iraq. So could you share a little bit more specifically about some of the lessons learned from that work and how we take that forward?
Sure, Monette. So as you mentioned, the work that we've done focused more on the interplay between conflict and cancer services and registration. And a part of what we did really, it sort of showcases how conflict hollows out health systems, right? So if we look at Iraq, in the 1960s, the healthcare system in Iraq was considered one of the strongest in the Middle East. It had the most advanced sort of care in general and also cancer care in specific. And by 2017, after the Iraq-Kuwait war, after the Iran war, after the US invasion, after the ISIS conflict, so after all of these sort of recurrent war, we ended up with a population, in this case, we're talking about cancer patients, needing to travel outside the country. And this is what we call cross-border travel for cancer care, into Turkey, into Lebanon, into Jordan, to seek cancer care. And if we look at this subpopulation, what we found is that more than 30% of the patients that went to the cross-border for cancer care, they had to sell their houses to be able to cover the expenses. And the lesson learned here is that patients with NCDs, especially if they are long-term and chronic diseases, in post-conflict settings, they will suffer from what we call financial toxicity, which is a very, very high level of financial burden. And when we're thinking about rebuilding healthcare systems, we need to develop these financial mechanisms to support these cancer patients. And the second point that I'd like to make, and this is the last point, is that conflict impacts the ability of the health system to collect, to store, to analyze, and to disseminate data. And what we've seen in cancer registration, and I assume this applies to a lot of the NCDs, what we've seen in the wars, and we've actually documented that in Sudan and Yemen and Syria, especially in prolonged wars, this actually completely halted cancer registration. In other words, there was no collection of data whatsoever on cancer population. So this meant that the ability to understand the patterns of cancer, the ability to develop population-wide screening, the ability to develop population-wide intervention was non-existent. So when we're thinking about rebuilding health information systems, we need to make sure that these systems are not only there, but they're also resilient, and we have the technical capacity in place. These are the 2 points that I wanted to make about this.
Fabulous. Thank you so much. And I'm sure we will come back to some of them as well. But for now, I think I'm going to move to Dr. Hitti, Eveline. You helped to develop the first emergency medicine training program in Lebanon in 2012 and have led the emergency department at AUB through a number of crises, including the Beirut blast and, of course, COVID-19. So perhaps I could ask you to reflect a little bit with us on the health workforce specifically. I mean, Zahi already brought up the issue of training, but helping us to understand a little bit more about the particular needs of the health workforce. And in the current crisis in Gaza, we've seen health workers directly under fires in ways that are really quite unprecedented. So how should we think about human capital needs in any health system reconstruction? And based on your own experience, what are some of the challenges that we are likely to face in reinforcing and rebuilding the health workforce in the aftermath of war?
Thank you, Monette, and thank you, Zahi, for setting such a perfect ground for what I feel is one of the biggest challenges for workforce retention and building in places where conflict is endemic. And I think that is the key challenge that we face in both health workforce planning and retention. So I left Lebanon when I was 5 in 1982 when Israel invaded. And with the hopes of coming back, the family left within a day, having intended to just leave for a couple weeks. And 27 years later, I returned with the naive, I think, purpose or interest in helping rebuild at least emergency medicine, or build emergency medicine in a country where emergency medicine was still a young specialty. So we started the first emergency medicine residency and training program, got accredited, built the faculty, recruited faculty from overseas to be able to train. And then 2019 hit with the banking and financial collapse, followed by COVID, and then the Beirut blast, where my faculty, my team was at the forefront of that response. Within a few months, all the faculty that we had recruited went down to 50%. Our nursing, 50% of our nurses left. So we were facing a skeleton workforce after having put so much work into building that team. And now a skeleton workforce facing the COVID surges that came and then the civil unrest that followed within that period. So reflecting on that, I think there are the key challenges is that what happens in low-income countries, especially in low-income countries where conflict is endemic, is that in places like Lebanon, like Syria, like Iraq, it wasn't an issue of lack of local capacity building bandwidth. It's an issue of workforce retention. So we have, and we build capacity, and we have, in Lebanon, there are 9 medical schools for a population of around 5 million. So we actually graduate a lot of expert trainees. However, we export them. So these low-income countries paradoxically end up exporting much of this human talent, capital talent, to high-income countries. So a 12-year retrospective of where our graduates are from our program, we've graduated 40 residents or specialists in emergency medicine. And out of those 40, 9 have stayed in Lebanon. And the reasons for the departure are many. Of course, the instability is key to that. For faculty in my department, for me personally, the decision to leave or stay amidst the convergence of crisis was not an easy one. Professional growth, professional development, am I going to be able to continue to educate my kids? The basics of electricity supplies, caring for patients with the basic needs and expectations that we have of ourselves as physicians, all of those are important considerations that end up driving health professionals out. So that's definitely, I think, a key consideration, especially in our area where there is a lot of local capacity building, and that isn't necessarily the problem. It's really focusing on retention and how do you, amidst all of this uncertainty and stability, continue to retain your own talent. And that's a lengthy discussion, and we've started shifting since the crisis a lot of what we are doing in terms of recruitment of trainees, thinking about what after training, in terms of selection, in terms of thinking with the candidates about what their career paths are, especially for subspecialties where we know that these are needs of our community. The second thing that I wanted to talk about is in terms of workforce planning. So, and how do you recover post-conflict? So we had the massive departures from Lebanon as a whole, not just our institution. And as a result, you're left with practitioners potentially working outside of the scope of their practices. And how do you want to elevate their training levels to be able to care for the needs of the patients and the community? So this is where capacity building does come into play. And there is certainly a lot of funding that is coming in for capacity building. And here, I think it's really important to make sure that that capacity building is looking at developing competencies that are in line, again, matching the needs of the community, but also not undermining the existing programs and infrastructure, which can often happen when agencies come in without partnering and collaborating with local infrastructure and local experts. So parallel capacity building channels come, and some end up underlining the more formal infrastructure. Which takes me to the third thing, which is really the need to bolster existing infrastructure. So amidst these crises, with so much faculty departure, with resources plummeting, certainly all the medical schools and training programs suffer. So rather than have parallel systems, how can we really post-conflict bolster the existing infrastructure back up and spend resources towards that, alongside some of the parallel structures? But I think that is the more important one, rebuilding the existing infrastructure for capacity building before forming parallel tracks to elevate the competencies of the existing workforce. So those are really that's my experience, and where we're shifting focus is, again, as we build capacity, we have the bandwidth, especially in places like Lebanon. Gaza is going to be a very separate and very difficult challenge. I think that's unprecedented, with the level of destruction of the education system, the hospitals that are needed for on-site training, especially for healthcare. It's not just about the universities, it's about where do these physicians and trainees get their clinical hands-on training. So I think that challenge is going to be a very difficult one, and we have to be very creative in thinking with Palestinians about living on the ground and experiencing it and knowing what the needs are, how to help rebuild there. But for us in Lebanon, it's really shifting the mind frame about retaining the graduates that we have. We have excellent training programs, and we need to just think about creatively about retaining those graduates, not allowing for such easy migration out and accelerating, sometimes doing things that accelerate the out migration ourselves in terms of how we're building our training programs. And then bolstering existing infrastructure to build local capacity. And finally, certainly there's always a competence-based capacity building alongside the traditional models. There's always room for that as well.
Thank you so much. Just one final question, maybe in 2 minutes. But, both listening to your reflections and those of Zahi, I'd love you to just share a little bit what you think might be some of the regional sort of infrastructure or capacities that we can leverage in support of health system reconstruction. So, thinking about what resources can be used to facilitate in the rebuilding, for example, of the health system in Gaza.
Yeah. So again, I think key is understanding what Palestinians and physicians and experts and academicians in Gaza feel the needs are. I think we all have a sense of how decimated the systems are, but really partnering with them to understand what the needs are. Thinking about how do you try to build up existing infrastructure there, not just taking trainees out to regional programs, though that is definitely going to have to be one of the solutions, and partnering with regional medical schools and training sites to take trainees who no longer have sites to train so that they can continue their training. And finally, really thinking about how we can use virtual modules and virtual didactics and curricula to help deliver some of the content that's needed. It can't complete the entire training program, but I think there is definitely room for that, and the opportunity to leverage virtual training programs and asynchronous training programs that we can all pitch into. We have the language, we have the expertise in the region, and how can we use that to supplement what's the needs in Gaza and in all the war-torn areas.
Great, thank you, so helpful, and it may end up being critical given constraints on mobility and freedom of movement in the region too. So thank you so much for those thoughts. So moving to our final panelist today, Saman Zia-Zarifi, and just a reminder, please do put your questions in the Q&A box if you have any for our panel. So, Sam, Physicians for Human Rights has covered extensively the deliberate targeting of health infrastructure and health personnel in many of the current crises we see in the region, particularly in Syria and now in Gaza. So I wonder, from your perspective, what broader issues are reflected in these disturbing trends, and how does this shape what needs to happen when the conflict ends, both as we plan for reconstruction and also how we engage with state and non-state actors to reinforce and restore respect for humanitarian law? I mean, James opened up that discussion early on, and so we're coming back to you to sort of round it off for us.
Thank you very much, Monette, and thank you for inviting me to join this very distinguished panel. And I have to say, I'm a lawyer, though I'm at Physicians for Human Rights, and so it's very interesting always to hear kind of the experts and the scientists and the clinicians talk about their experiences. So let me do what lawyers do, though, which is to talk about some of the norms and maybe try to give some shape to the very interesting and useful advice that we heard. As you mentioned, Monette, Physicians for Human Rights has been documenting attacks on healthcare, especially in the context of conflict, for years. And you know, just to go back to it, the very basis of the rules governing warfare, and to some extent even human rights, go back to the notion of protecting healthcare provided to combatants and then to civilians, back to the 19th century. So this has been really the core of the international legal framework that we're working with today. And of course, after every calamity, after every catastrophe, and in particular after the Second World War, we really saw the development of those norms through the Universal Declaration of Human Rights, and then the Geneva Conventions, and the framework that grew from those two. I cite all that because the norm prohibiting attacks on healthcare was developed under international humanitarian law, the laws of war, and really was a bedrock principle. The right to health was developed in the International Covenant on Economic, Social, and Cultural Rights out of the International Human Rights legal framework, and that's also really been in place now for what, more than 50 years. What is very alarming in our research is to see that, especially in the last 10 years, we have seen increasing violations of the norm prohibiting attacks on healthcare. And so this has been done, it always happened. It always happened, of course, during conflict, but it was viewed as something that was egregious, that was wrong, and that was problematic. And what we've seen increasingly, I would say, at least in my view, it started in Sri Lanka with the war against the Tamil Tigers. It then escalated. We saw it severely increase in Syria, especially after Russian forces joined. Then we saw Russia use the same tactics in Ukraine. So until October 2023 was already on track to be the worst year in terms of attacks on healthcare facilities, as we had recorded it. And of course, now in Gaza, what we've seen, the numbers really go off the charts. And of course, it's not just there. We've seen similar attacks in Sudan, which we've mentioned, in Myanmar. So it does seem like that norm is under attack. Now, we already had seen this in 2016, looking at what was happening in Syria. We went to the UN Security Council with overwhelming support from the world's states, and the UN Security Council issued a resolution saying, really, you can't attack healthcare facilities. We just want to remind everyone. Of course, that has not really had any impact, in part because some of the Security Council members themselves have been really engaging in violations. So in light of this, in light of the fact that we've seen really rapidly increasing attacks on healthcare, why do governments, why do combatants do it? Because it's really effective. It's a terrific way of degrading a population's resilience and of undermining an opponent's ability to fight. Therefore, we really have to think, so what happens the moment that the conflict stops? We've heard really important concrete suggestions about that. But like I said, let me go back to some basic norms that may help put a framework around what we've heard. Important to note, it may seem clear, but today maybe people forget it in light of the atrocities that we see around the world. The whole point of international law, including humanitarian law, including human rights law, is to make conflict more difficult. It's to constrain the ability of warring parties to do what they want to do. And that's really a crucial point. So the norms were developed to make it more difficult to attack a party, to do things that would damage a party, and even to win if that's what you want. So both of the frameworks of the laws of war and human rights law have significant normative suggestions for responsibilities and the content of what it means to provide health in a conflict and in a post-conflict situation. To point out, and again, whether it's a conflict or even after a conflict as defined by humanitarian law has ended, there is no moment that is a human rights-free moment. Even during a conflict, international human rights law applies. It's just that during conflict, humanitarian law also applies. Now, humanitarian law is pretty clear. If you've won a war, so to speak, if you've occupied territory, you have obligations as the occupying power to ensure for the basic health and well-being of the occupied population. This is true under the Geneva Conventions 4, Articles 55, and going up to Article 60 or so. But crucially, it's also clear under international human rights law. And this is where the right to health under the International Covenant on Economic and Social and Cultural Rights has been developed, and we've seen the Committee on ESC Rights be very clear to say that there is no derogation from the right to health, even during conflict, and parties to the conflict have an obligation to ensure this. Now, after a conflict, so again, if you're an occupying power, you continue to have responsibility for the well-being of the people that you're occupying, even if you're not fully in control. If you're not fully occupying, even as a so-called invading power, you still have obligations. And so this is crucially true, of course, in the occupied areas of Ukraine, where Russian authorities must provide healthcare, adequate healthcare, and I'll get to that adequacy issue, to Ukrainians. And of course, in Gaza now, regardless of the discussions that we've seen previously from the Israeli government, in much of Gaza, now Israel is the occupying power, or maybe in some areas the invading power, but it does have a responsibility to ensure that for the health and well-being of the population, whether directly or by enabling access by international humanitarian organizations. In a post-conflict situation, well, what's the responsibility? If the war ends with not with a power who's occupying, but with the two separating, international law, again, gives us some standards about what is supposed to be the quality of care. It says that care must be available to the extent that is possible. It must be accessible and non-discriminatory in terms of access. It must be acceptable, and it must be of a quality to the extent that the government can provide it, that is scientifically and medically suitable. And those are some of the standards that Zahi and Eveline and James have really talked about. It's a struggle, but it means that whoever is in charge must look at the post-conflict situation, at the rebuilding of the healthcare system with those standards of adequacy. And the responsibility, look, if the occupying power, I said, will have obligations, that's fairly clear. If there is a separation, it's the responsibility of the government that takes charge. And that also means that if you're a non-state party and you are effectively in control of the population, as was the case with Hamas for the last 10 or 15 years in Gaza, you have that obligation to provide that standard of care to your population. And you cannot just forget that obligation. You have the obligation to not militarize hospitals and healthcare if you have. There are those allegations. And we've seen a lot of that from Russia in the Syrian context, from Israel in the Gaza context. And that's why, finally, there has to be accountability for violations. There are many of these allegations of militarization, allegations of attacks on healthcare. That's why there has to be independent, impartial, credible international investigations, because what we have right now are allegations and counter allegations. We need to establish the facts because there has to be accountability. Accountability under IHL can mean potentially individual criminal liability, but more broadly under international law, it's the responsibility of the warring parties for potentially to provide restitution for the healthcare facilities that they've destroyed and for the rebuilding of those healthcare facilities, and for the international community to provide assistance to the rebuilding parties. I think that's just a basic human rights and humanitarian obligation. But as we've heard, because we know, as PHR's research from around the world has shown, that conflicts severely, obviously, degrade healthcare systems and lead to the reemergence of communicable diseases and horrific non-communicable disease problems like famine, which will have regional impact. And so the rebuilding in a post-conflict situation does have to follow the international human rights standards and does require a combination of national, domestic commitment, international assistance, and where applicable, accountability and restitution by violating parties. Let me stop there.
Thanks so much, Sam. I had a follow-up question, but I am mindful of time, and I also see that we have some very rich questions coming in through the Q&A box. So I will come back to you with my final question towards the end, I think. But let's pause now. You've all surfaced such critical issues for us to think about, and our audience has been responding, as you would expect, with a number of questions. So I'm going to read out a couple of them, and we'll take 2 or 3 questions at a time as a panel. So first of all, we have a question about data and how we, as a humanitarian and public health practitioners, go about verifying the accuracy of reported data and safeguarding, and ensuring that the figures that we're relying on, that we're using as the basis for our planning, for our advocacy, are reliable. And I think a follow-up to that question comes to, is there an obligation to distinguish between civilian and combatant fatalities and to verify the accuracy of casualty figures? So that's one set of questions on data. I think it's a very common feature of many conflict zones that the data itself is disputed. So perhaps I might come to you, James, in a second, Sam, also to you, but also any of our other colleagues to answer that question. I think we have a second set of questions here related to the issue of reproductive health and asking us to speak a little bit to the question of reproductive injustice in war or conflict settings, as well as some of the potential interventions that could feasibly be implemented. So thinking, I think, there about some of the particularly vulnerable groups that perhaps we should spend a little bit of time reflecting on: maternal health, women's health, and how we think about that going into the post-conflict setting. So that is a second set of questions. And I think at this time, I will also take 2 questions together. One is, why aren't we talking about healthcare reconstruction in Syria, given that there's a sense that the conflict there has concluded? And then how do we think about the fact that there's a report that says that healthcare reconstruction in Gaza is going to take decades? So it's really a question about, well, when do we start the process? And how do we live with the fact that processes of reconstruction can take decades? So that's why I lumped those 2 together. But let's start first with the question about data and ensuring that the data that we have is accurate, particularly in these highly politicized and conflictual settings. James, can I come to you first to talk a little bit about that?
Yeah, I would say, look, there's many, many operational dimensions to appropriate data collection, to verification, to ensuring that the indicators are the appropriate indicators and so on. There's many, many dimensions. But I think the critical issue here is the credibility of the source. That is ultimately the question. In the heat of a particular moment, and particularly the heat of conflict, the credibility of the source of the information is absolutely crucial to adjudication, to political engagement around that particular piece of data and what it may mean for protection of rights, protection of civilians in conflict, and so on. And I'll just say that now, I don't speak for MSF now, so I want to be very clear about that. But I do want to say that in my experience with MSF, we have been absolutely rigorous about the technical and operational and epidemiologic principles that we apply to the collection of data in a particular conflict, and in when and where and how we choose to use that for advocacy or for bearing witness purposes. So the credibility of the source, however, is the critical issue. And that's based on trust. And it's based on trust that is rooted in prior experience. So how others see that source relative to their prior experience, do they trust them? And can they therefore impute value and independence, in this particular case, to the credibility of that particular piece of data? Now, that is an inherent political process over many years. So that when an organization, like, for example, Physicians for Human Rights, when PHR speaks, people listen. And they listen because of the credibility of the source. And that credibility is based on rigorous application of the kind of principles that I've just talked about. So that in the heat of a moment, when PHR or Amnesty or MSF, when they actually speak or bear witness to a particular circumstance, there is significant meaning and significant power and authority associated with that exertion, if you will, of new knowledge. So I also want to just say that, you know, the bearing witness is absolutely critical to the recognition and the application of humanitarian law in war, or the laws of war. And I also would just like to remind that, and I'd love to hear Sam's comments on this, you know, law is, I mean, Koskanini was a great jurist and a great thinker in terms of what is law and why does it matter. And I may get this wrong. Sam, you can correct me if I get it wrong. But he said there's three elements to law. One is that law constrains. The second is that it enforces. And thirdly, it's a persuasive force, right? It's, in that sense, it's a normative force, and that these three strands are not independent of each other. And this is why I think it's extremely important in a particular conflict that those actors who call themselves humanitarian, that they are constantly engaged in a dialogic, persuasive process of constantly referring to the basic laws of war and to bearing witness when those laws are violated, and most especially around war crimes and data-based, obviously, and most especially around genocide, which is, you know, it's the final frontier, if you will, where there is no humanitarian space by definition. So bearing witness, the credibility of the source, and recognizing that these are part of an ongoing surrounding political process wherein the humanitarian is claiming to be an apolitical actor, but is trying to the best of their ability and to the best of their resources to act in a manner that respects the dignity of all people, and most especially those who are victims of war.
Mm-hmm. Thanks so much, James. I think you've answered the data question really quite conclusively. Do any of the other panelists have anything they want to say on that specifically before we move on? Oh, Sam, go ahead.
Monette, just to say, of course, the distinction between civilians and combatants is the center of humanitarian law. And again, just to just to remind that it's the basic law is that there is a right to life and that no state can arbitrarily deprive anyone of the right to life. And at times of conflict, we provide a special dispensation for states to kill combatants, but to discriminate between combatants and civilians. And therefore, it's the obligation of the states that are doing the killing to show that they have distinguished between civilians and combatants. And so what we've seen is a significant development in many militaries around the world of capacity internally to do that investigation and to show clearly when there has been an attack that has involved civilians, that there was proper distinction between the civilians and the and combatants, and that the state did everything possible. And as James pointed out, it's precisely this is where international accountability comes in, because when there is a case where there is a violation, where there are attacks on civilians, where civilians are killed, there has to be an investigation and to make sure that the state did what it could to distinguish between the two. And James brilliantly put out how that's done. But going to, I mean, he cited Koskiniemi and the issue of enforceability and accountability, just to say that although the norm prohibiting attacks on healthcare is foundational and one of the oldest in international law, as far as we know at BHR, there really has never been a successful case brought against anyone for violating that norm. And that's where we are now. That's why we are working with the ICC. We're working with international mechanisms to ensure that there is accountability for that, because until there is accountability, the violations will, we think, continue and probably get worse.
Thank you so much. So we have two more clusters of questions left, one specifically about reproductive justice in conflict settings and thinking about the healthcare specifically of women and girls in these settings. And then we have the second set of questions about when to start and when to end. And I'm conscious we have a minute left. So looking to Eveline and Zahi, would you like each one of you to take one? I'm also happy to weigh in if you're interested in supplementary support here. Who would like to answer the question about maternal health and reproductive justice? Eveline.
I mean, I can take a stab at it, though. Just speaking from an emergency physician at the front line and someone who's looked at impact on health sectors in conflict and diseases that emerge in conflict. So in the occupied territories, even prior to October 7th, there were huge disparities in health outcomes of both maternity mortality and infant mortality between Palestinians in the occupied territories and Israelis. So because of all the different social determinants of health, whether it's the access to medications, the health infrastructure, supplies that are coming in, malnutrition in general. So now we're looking at a health sector where 10 out of the 36 hospitals are partially functional, where primary care centers, also a fraction of them are minimally operational. Add to that the surge of all the communicable diseases. So we're looking at over 600,000 acute respiratory infections, more than 300,000 diarrheal cases, hepatitis A epidemics, chickenpox epidemics, and the famine and malnourishment. That all of these are certainly all predictors and associated with worsening maternal mortality. So you're essentially not just looking at women who are pregnant, the 50,000 that started in October who were pregnant, looking at lack of access, but also facing all of these diseases without the right infrastructure to take care of them. I don't have any data on what that impact on outcomes is, but you can imagine how, given how poor it was compared to the region, where it is today, and the devastation in terms of what women who are pregnant are facing, as well as infant mortality.
Thank you. So Zahi, you have the last word for 30 seconds before I hand it over to Tanya, maybe just specifically on the length of time that it's going to take to rebuild some of these systems. And you alluded to that in your remarks about the fact that this is a process. So maybe just 30 seconds of final thoughts on the length of time we have to engage.
Yeah, so I'll try to say that in a sentence. So it's really hard to anticipate that, right? It depends on whether, I mean, in Gaza, for example, it depends on whether and when these populations go back and when the situation happens. But I think what is important at this stage, even though the war did not end yet, it is to start planning, right? It is to start planning for the aftermath of this. It is to have conversation, and we, at least at AUB, we try to include these conversations in all of our events and all of our sort of conferences that we go to, because the more conversations we have, the better we are prepared, hopefully, the better off the health system will be when the war ends.
Thank you, Zahi, and thank you to all of our panelists for such thoughtful reflections and insights. I really, really appreciate it. And for the last word, I'm going to hand it over to Dr. Tanya Haddad, who is Associate Professor of Public Administration and Nonprofit Management at the AUB, also the Director of the Global Engagement Initiative. So over to you, Tanya.
Thank you, Monette, for your moderation, Sam, Zahi, Eveline, and James for your valuable input. As we reflect on today's panel, it is clear that addressing humanitarian and medical challenges is imperative in the aftermath of conflict. Today's discussion has highlighted the crucial role played by humanitarian organizations and medical professionals in navigating the complex landscape of post-war recovery. From coordinating resources to delivering essential services, providing online training and support, the strategies discussed underscore the resilience and adaptability required in rebuilding shattered communities. As we reflect on the insights shared by our esteemed panelists, it's evident that effective post-conflict fieldwork demands not only practical expertise, but also a deep understanding of the unique dynamics at play in each situation, as there is a need also to prioritize and sequence responses based on the nature of the conflict and its impact on civilians. As we move forward, we should remain committed to learning from past conflict as we explore innovative methods for post-war rehabilitation and transitional justice. This panel today was the second of a series titled After War, Learning from Past Conflicts, a collaboration between Columbia Global Centers Amman and the Global Engagement Initiative at the American University of Beirut to further the academic and public discourse around post-war rehabilitation, societal recovery, and transitional justice. The Global Engagement Initiative at AUB aims to contribute to AUB's mission of advancing global knowledge by fostering partnership worldwide. In conclusion, I would like to invite you all to join us for our upcoming panel on May 7th, where we will delve into the mental health effects of war and healing approaches. Thank you, everyone.